It's a pleasure to invite Dr. Usha Sriram, Professor Usha Sriram. She is a graduate from Madras Medical University. She is the head of Department of Diabetology and she is a renowned endocrinologist of Voluntary Health Services. She has a special interest in GDM, osteoporosis and medical ethics. Welcome you, ma'am, to give a talk on osteoporosis.
The topic is on osteoporosis, a life course approach for an OB/GYN.
Good afternoon, everyone. And thank you for this kind invitation. Especially, I want to thank COGS for this special invitation to speak on this very, very important topic, which is bone health, that you all will be taking care of women from the time they are small girls all the way to old age, what you can do for prevention of osteoporosis and also for maintaining bone health throughout their life. So I thought I'll just speak on bone biology and the definition of osteoporosis, scope of the problem, and then different stages of a woman's life, and finally approach to osteoporosis. As you can see, this life course approach is very, very important, especially in osteoporosis, which we always say has pediatric origins for a geriatric disease. Everything starts actually in a young girl. So very, very important to maintain their health throughout, starting from preconception health of the young woman to the baby in utero, to childhood, to adolescence, and then adulthood, and of course much late menopause. The problem is huge, predicted to reach, as you can see, phenomenal numbers in Asia by 2050. And we also know that while fracture risk increases with aging, especially we are concerned about vertebral fractures and hip fractures, as you can see also the morbidity goes up significantly. Whether it is with vertebral fracture or hip fracture, the morbidity, most people die within 20% die within 1 year of a hip fracture. 20 to 30% never return to their previous level of functionality. And then there's an increased risk of subsequent fractures also. And if you look at the pathogenesis of an osteoporotic fracture, you can see how this life course approach is very important. So the low peak bone mass, that the peak bone mass is attained in the late teens or early 20s. So a big portion of the skeletal bone mass is achieved in childhood and adolescence. So if anything happens, nutritional or otherwise during that period, they're going to start with a lower peak bone mass and therefore greater risk for fractures and osteoporosis. Then there is menopausal bone loss. So if menopause happens early, they are again going to be at greater risk for fractures. Then there's the age-related bone loss. So all this low bone mass, and plus there may be other risk factors. There may be diabetes, hyperthyroidism, or other endocrine disorders, or use of certain medications, other conditions, GI conditions. Then there are non-skeletal factors like propensity to fall, eye problems, or coordination problems, or neuropathies, things like that. So all of these things put together, there is a risk for fracture. So we have a responsibility to make sure the peak bone mass is proper. We want to make sure that postmenopausal bone loss is addressed. So I'll go through that. And as you can see from here, the peak bone mass is attained in the late teens to early 20s. Then there is a plateau, and then you can see that there is an age-related small amount of bone loss, and then an abrupt big loss around the menopause and perimenopause, and then age-related bone mass is resuming. So much so that they almost return to their adolescent levels earlier. So eventually back to pre-adolescent levels. And factors that are influencing the peak bone mass, as you can see, many things. Very, very important, gender, meaning girls have a lower peak bone mass. And nutrition is very important during adolescence. And of course, endocrine factors. So if a girl has hypogonadism, for example, and not having estrogen, chances are they're not going to have the adequate bone mass, physical activity, body weight, smoking, alcohol, and other factors. Then what about in pregnancy, the next step? And For example, low vitamin D levels during pregnancy has multiple consequences. We only think in terms of bone, but you can see from everything from preeclampsia to altered placental vascular pathology to increased risk of C-sections, increased risk of GDM, and then infection rates, brain function. So many things are affected by vitamin D, and more recent things to abnormal fetal growth patterns and abnormal birth outcomes also, and preterm birth. All of this is happening because of vitamin D. And I also want to say that there are some unique things like the placenta may synthesize 125 dihydroxy-D and metabolite in maternal circulation, though it's produced by maternal kidney. So this is very, very important for increasing intestinal calcium absorption, what the mother does. But what the placenta does has important immunomodulatory properties. And so you can see what happens in women during pregnancy and lactation. Normal is this is normal. During pregnancy, you can see to increase the calcium absorption, and therefore the bone becomes weaker. Osteomalacia of the bone happens. But then look at lactation. It's again another very big drain on the bone, and the PTH-related peptide is also working in that area. So very, very important slide I want to show, showing that vitamin D has major implications for fetal development. So much so we are now seeing the fetal origin of adult disease. Vitamin D deficiency is also an important contribution. Everything from what is happening in the infant, asthma as a child, and then other metabolic and cardiovascular disorders later on, and then of course sarcopenia, myopathy, osteoporosis, cognitive impairment later. So important to keep this all, the levels optimized. Just want to show a historic radiograph. I'm not sure if you can see cephalopelvic disproportion from maternal vitamin D deficiency, and the head is stuck there, the baby cannot come out, and also increased risk of preterm birth. Vitamin D involved in the prevention of preterm birth are related to its immunomodulatory capacity, which is very, very important for us to keep in mind. And this is important because we have to improve the vitamin D status of the mother before she gets pregnant, ideally. And then at least want to make sure that during pregnancy it is optimized, but really most important before pregnancy. As I mentioned, very important to remember the PTH-RP is also acting during lactation, increasing the resorption of the bone. A quick review of the vitamin D metabolism to say that there is only one source of vitamin D really, that is the sun, and the skin manufactures the vitamin D. The vegetarian diet has zero source. The vegetarian diet has zero vitamin D. Unless it is fortified, unless milk is fortified or something is fortified, zero vitamin D in vegetarian food. So non-vegetarian in India, even people who say they are non-vegetarian eat on Sunday, one meal. So for all practical purposes, we are vegetarians, which means we don't have any vitamin D in our diet. We have to get it from the sun. And the reason we don't get it from the sun, I just want to tell you lots of reasons. Indoor environment, extensive clothing cover, avoiding the sun, air pollution, exposure through glass, dark skin pigmentation. The darker you are, the less you absorb. Malabsorptive syndromes, obesity. So many exclusive breastfeeding, pregnancy, aging, all of these things contribute to vitamin D deficiency, which again we really have to talk to our patients about their exposure to the sun between 10 o'clock in the morning and 4 o'clock in the afternoon. That is the only time you get the UVB rays, not early morning walks or late night walks. And this is the dietary recommendation of calcium and vitamin D. I just want to show you that, early years also you need adequate calcium and vitamin D, and again during pregnancy, lactation, and after, in the postmenopausal years. You have to take a history about, how much calcium and vitamin D they are getting, and supplement ideally about 500 milligrams of calcium. Elemental calcium once a day is enough for most postmenopausal women, and they must get at least 1,000 units of vitamin D per day. Some may need more if they are obese or have other complications. Then as people get older and become menopausal, I just want to say that Fuller Albright observed that a large number of his patients with osteoporosis were postmenopausal women, and he speculated that estrogen is possibly playing a part. Not just menopause, you can see even early and late perimenopause, especially late perimenopause, people are losing bone. So it's not just postmenopausal. You already start losing in late perimenopause, and of course clearly postmenopause. And estrogen has a very, very important role on the bone, from osteocyte action on osteocytes, activating bone remodeling, action on osteoblasts for maintenance of bone formation, and osteoclasts to decrease the bone resorption. So naturally, when there is estrogen deficiency, all of these things are going to be reversed, and there is going to be greater amount of bone loss. So quickly, osteoporosis used to be defined as a systemic skeletal disease characterized by low bone mass, microarchitectural deterioration with consequent increase in bone fragility and susceptibility to fracture. So now we are saying osteoporosis is loss of bone strength. And bone strength has two components. It's bone mass and also bone quality. And bone quality is affected in diabetes and many other conditions. So we may not be able to measure it with a bone density, but bone quality is affected in them. So that's how it happens, and this is how it is defined. So normal is -1 to up to -1. Osteopenia is -1 to -2.5. And osteoporosis is -2.5 or obviously anything more than that. And severe or established is if they've also had a fracture as well. So when you see a person with osteoporosis, no one is going to come and tell you I have osteoporosis, except maybe in my clinic referred by somebody, but otherwise they won't, because osteoporosis is a painless condition, no pain, nothing. The only symptom people have is they break something. They come with a fracture, so they go to an orthopedic surgeon. So our job is really to prevent the fracture. So we cannot be asking them, do you have osteoporosis? We have to think of it. So a good history physical, a very basic laboratory exam which consists of at least a serum calcium, albumin, a hemoglobin, at least that much. If you can do vitamin D, great. If you can't do that, at least a history. And imaging, like a DEXA. And definitely if the DEXA shows osteoporosis, then you have to get, and then a FRAC score, which we have already talked about. X-ray is super important. We don't do it. Every patient diagnosed with osteoporosis must get a spine X-ray, because if you break your thigh bone or you break your arm bone, break something else, you will know about it. If you break your spine, you won't know. Though back something people will do, put some Bengay, this, that, and or they may just think it's part of aging or something like that, and then they get shorter and shorter, or they get kyphosis because their spine has collapsed. So the only way you will know is to do an X-ray. And the more, if there is a fracture of the vertebra, you can see the risk of greater the number of prevalent vertebral fractures, greater the risk of future fractures. So your risk stratification completely changes if there is a vertebral fracture. FRAX is an online tool, so very, very easy to use. We have that for our country. You just have to put India in there, and you can put in the risk factors. There's nothing for diabetes, so if you're a patient who has diabetes, you have to put in rheumatoid arthritis. Or what you can, so rheumatoid arthritis in this. And if you do a DEXA, then what you can do is, if they have diabetes, you can add another half, meaning if they are -2, it's really -2.5. So you have to make those adjustments. So when we are doing a DEXA, we order a spine and a hip, an L1 to L4, and then they give it as T-scores and Z-scores, and then we also do a hip. Just the spine and the hip is enough to make the diagnosis. So a good history and physical, very, very important, and on all those tests that I just, showed you. And then we have to, once we have made the diagnosis of osteopenia or osteoporosis, we have to prescribe calcium to them, take a good history, prescribe the diet, and then prescribe calcium supplement. As far as vitamin D, I already told you, only sunlight, sunlight, sunlight. All other things are all fortified foods or non-vegetarian foods. So nothing in vegetarian food. So multivitamin supplements, this is in pregnancy, usually contain only 200 to 400. Is this sufficient for general population, but not for people who are deficient or for people, let's say, pregnant, breastfeeding. You have to give them more, and you have to absolutely make sure that they get the sunlight at the right time. And supplementation, you can give them 60,000 units once a week for 6 weeks, followed by once a month for 6 months, or you can give it to them every day as 2,000 units, which will add up to 60,000 units a month for maintenance. You can do it like that also, depending on if people want to take it every day, or they take it once a week, or they can even take it once a month. So make sure you give calcium, make sure sun exposure, weight-bearing exercise. There's also proof now that sleep is important. Make sure they get sleep, avoid alcohol, smoking, even e-cigarettes, and limit the intake of coffee. Maintain their vitamin D either to an acceptable, ideally, to an ideal level, which is 30 nanograms to 40 nanograms or a little bit higher. This is very, very important. And this is, I think, my last but one slide to show you the management of osteoporosis afterwards, after all this, medication-wise, is something a little bit more nuanced. So once you have done the DEXA and confirmed the osteoporosis, we choose either they go on anti-resorptive therapy or they go on anabolic therapy, depending if they are high risk and no previous fractures, or very high risk prior fractures, depending on what their BMD is, depending upon what their frac score is, their other risk factors, and if they've had fractures, we have anti-resorptives like bisphosphonates and denosumab. We have anabolics like teriparatide, and now we have newer ones called romosozumab, and we have abaloparatide, which hasn't come to India yet. So we have some good medications, and I think that is a little bit more nuanced care. More importantly, as OBGYNs, what you have to do is, whenever you see young girl, or you see mothers, grandmothers for other things, you talk to them about the nutrition of their girls so that the peak bone mass comes up. Make sure that prior to pregnancy, pre-conception, the calcium intake is optimized, vitamin D intake is optimized. During pregnancy, you make sure that the adequate calcium and vitamin D are given, and during breastfeeding. And then also make sure that people do not go on crazy vegan diets and other things that make them, more deficient in the bone. And postmenopausally, make sure they get adequate calcium in their diet and give them 500 milligrams of calcium per day, and also adequate vitamin D. And as far as medication therapy, I think that's a slightly more nuanced treatment. Hormone therapy for osteoporosis is really not done anymore, or it's for a very small group of people who either cannot take these other medications or need the hormone therapy for vasomotor symptoms. Side by side, they're also going to get a benefit on their bone. So this is the approach. And older patients, please talk to them about fall prevention. Most important service you can do for them is not to fall and get fractures. On that note, thank you very much.